before we start anything, tell me a little bit about your background.
Well, I went to Stanford University and got an undergrad degree in economics with a minor in French. And then I worked at IBM and went to Harvard Business School and graduated from Harvard Business School and was in high tech for many years. And then after that, I was the vice chair of a $1.8 billion hospital in Ohio.
And you are now the president of ATAC.
Yes, which is the Addiction Treatment Advocacy Coalition. And our primary goal is threefold. We advocate on behalf of addiction treatment providers, as well as those who suffer from substance use disorder. And so how do we advocate? We advocate administratively, meaning dealing with the regulators like the Department of Insurance, the Department of Managed Healthcare, and the Department of Labor, who manage insurance companies. We also do legislative work with California legislators to create laws that are beneficial to those who suffer from substance use disorder or those who provide treatment. And then finally, if those two actions don't work, we monitor and help folks understand what their judicial actions can be if we are not getting success in the other two areas.
I want to read back a quote from an article that you wrote in December 2016. You said that the California substance use treatment industry is under attack. An unsustainable model, reimbursements that do not support the infrastructure required by the Department of Healthcare Services, the Joint Commissions, and insurance companies, direct payments to clients that are often uncollectible, and blatant mental health parity violations. What can a facility owner do?
Substance use treatment providers are generally small facilities. There are some that are larger, obviously, but generally the people that provide treatment have one facility or two facilities. What is happening is a variety of things that are putting the treatment providers under attack. For example, there's something called the California model, which says that anybody can establish a treatment facility in any neighborhood that's 6 beds or less. Well, the 6-bed model doesn't work when you look at what is required for treatment. So it puts treatment owners under attack. And the reason is the California model, which has established that 6-bed facilities for detoxification and residential treatment are the model. And you can put them in any neighborhood, anywhere. Unfortunately, the 6-bed model, based upon requirements of the insurance companies, no longer is financially viable. The reimbursement rates have gone down substantially, and so 6-bed facilities have trouble maintaining a significant profitability in order to provide treatment. And so what you're finding is people are clustering facilities. That clustering of facilities has created a backlash in neighborhoods who are saying, oh my God, there are 2 substance use treatment facilities on my block, and that's negatively impacting my property value, et cetera. Well, the reason that exists is because the California legislator deemed that to be necessary.
Right, so the neighborhoods and the people, they're feeling kind of overrun by this. We live in a time now where treatment is more and more necessary. More people are coming into treatment than ever before.
Well, of course, because we have an opioid and heroin addiction crisis in America. So what happens is the doctor gives you a 10-day supply of hydrocodone or oxycodone. And do you know a 10-day supply is enough for someone to become addicted? So then they doctor shop and go until the doctor refuses to give them prescriptions anymore, and then they go and they buy heroin. And so this crisis is prevalent throughout the United States. Now they're prescribing drugs for people who have constipation due to overprescribing of opioids. I mean, that's kind of sort of ridiculous, but that's what's going on. And so we have a crisis. So access to treatment is the most important thing that we could possibly be focused upon.
I understand that statistically more people are dying from opioid overdoses now than car accidents.
And that speaks volumes about what's going on and what the state of affairs are in America. And President Obama allocated an additional $3 billion to sort of combat this opioid crisis. I'm not quite sure what's going to happen under the new administration, That remains to be seen. Obviously, Donald Trump's brother died of alcoholism. And so I hope that means that he's going to be focused upon treatment and understands how important treatment is for people who are suffering from substance use disorder.
Well, I want to get into some of the specific problems with the insurance industry and the out-of-network providers. But first, tell me a little bit about ATAC and why did you feel there was a need for this coalition? How did you guys start?
One of the things that ATAC is about is advocating for treatment providers and for those who suffer from substance use disorder. And good, bad, or indifferent, there's still issues around and there's still stigma around the fact that people suffer from substance use disorder. Now, there's no stigma around someone like myself who suffers from type 2 diabetes. You can say that's a substance use disorder too. My body's not producing insulin because I take in too much sugar or too much starch. But there's no stigma to having diabetes. However, there is still stigma around substance abuse. That is an issue that people believe is totally behavioral. You should be able to stop drinking. Well, I should be able to change my diet.
They think it's a behavioral choice.
Yes, and it's not a behavioral choice. And the American Society of Addiction Management says it's a brain disease. And so we understand that. It runs in families, just like diabetes runs in families, just like high cholesterol runs in families. The only difference is if you show up to the hospital and I ate 2 apple pies and now I'm going into a diabetic coma, no one passes judgment on that. But if I show up and I'm drunk, or I show up and I have done heroin, there's judgment that's passed. And that's the difference between the two things.
Right, and this gets into the Mental Health Parity Act, which we're going to cover in a minute. But first, I want to talk about the treatment providers themselves and the problems that they face financially and how they're supposed to be compensated and how the system actually works. Have you seen an increase in membership since this started?
This is our year celebration. We've been open 1 year. We represent over 150, 160 facilities. We have about 70 members, probably closer to 200 facilities. And so we are finally doing a membership drive. Your first year, you're just trying to figure out what are the issues, how are we going to go about it, creating a board, educating your members, and now we're going to say, okay, it's about strength in numbers. We want every single substance use treatment facility in California to be a member.
Yeah, you talk about strength in numbers a lot.
Even with our current membership, we shut down the website for the Department of Insurance. They said, oh, well, send us complaints. I said, okay, we'll send you complaints. And when we sent them complaints, it shut down their website and they called us and said, please don't do that. Can you send us a letter? Well, we had already sent a letter and they said, oh no, the letter wasn't good enough explaining the complaints. We need individual treatment facilities to do it because they thought we were not going to be able to create that. And we did. And it shut down their website.
Right, so requests for impact statements. I've talked to treatment providers and I've talked to individual clients on these policies that have been through an absolute nightmare in trying to get what they paid for. Basically, if I'm paying $650 a month for a PPO policy from HealthNet or one of the others, I expect to get what the policy states. But they're getting stonewalled, there's confusion, they're throwing up all these barriers. And I can't imagine the fight that you guys are going through now to break through that kind of quagmire.
And can you imagine where you call the insurance company, you get a pre-authorization, which they said, yes, for Fred Jones, you can provide the treatment. And then 180 days later, they say, oh no, that wasn't medically necessary, we're not paying you. So Fred Jones got the treatment. They're not going to pay us for the treatment. And they're saying it's not medically necessary. So, what are we supposed to do? We're supposed to bill Fred Jones $50,000, the guy who didn't have a job, who was addicted to heroin. It's a vicious cycle. And so there are a variety of issues besides pay to patient, because no treatment facility admits anybody without getting a pre-authorization from the insurance company. Yet the insurance company later says, we're not paying you.
And you're hearing more and more about these individual circumstances where someone's in treatment, say a week in for heroin addiction or alcohol addiction, whatever it might be, and they literally get pulled aside by a counselor, a treatment counselor, or somebody else, somebody in the business department that says, we have bad news for you. Your insurance was pulled today. You have to leave tomorrow, or you have to give us $30,000.
That is correct. And unfortunately, some of those people relapse and pass away. For the insurance company, it is not about what is best for your client. It is about, here's what we set up these arbitrary medical necessity criteria. What Aetna says is medically necessary for substance use treatment is different from what Cigna says. It's different from what United Healthcare says. Now, how can that be?
There's no set criteria.
There's no set criteria. Now, there are people who have put forth criteria, but they're not necessarily adopted, or they add something particular. Like, for example, one of the insurance companies now is saying you have to have suicidal ideation, meaning you have to say that you want to kill yourself.
To get into treatment.
To get into treatment. Well, I don't think that the average person who is addicted to alcohol wants to kill themselves, but they may need to get into treatment. Who decides what that's supposed to be? Who decides what the criteria is for your ability to seek treatment? And that's decided by the insurance company.
And they hang them up with these Dragnet audits, and they, as you said, they withhold payments, sometimes 7 to 10 months. They bombard them with codes, denials that are codes, and you can't get through to anybody. So
And half of the people who you get through to are in the Philippines. Okay, they're offshore. That's a whole different set of issues that I don't even want to get into.
These are violations of HIPAA laws.
Oh no, as long as the people who are working for the company adhere to the laws, they can do it in India, they can do it in the Philippines. There's nothing in the law that says they can't.
So some faraway employee, you get a denial of benefits, and they give you the code, and then they do a sweeping audit, and they say, send us all your medical records. These privacy laws, these medical privacy laws, the HIPAA laws, you mean they can send anything they want on me to anybody, anywhere around the world, and they're allowed to read that and decide if my treatment can continue?
Yes, and that's because the HIPAA law just says you can't share it beyond, employees and contracted employees. They can do that, and I'm not saying that that's against the law. I'm just saying that's a very unusual way of handling something.
Sounds more like they're saying you can't share it on Mars or Venus, but you can share it anywhere on Earth at any time with
Right.
anyone.
That's not illegal. They completely have the ability to do that as long as the appropriate HIPAA laws are adhered to.
It's a pretty scary reality.
It really is. And so if you talk to some families who have been through this and they've paid the $700 premium for the last 5 years, and then one of their children is addicted to a substance, and then they go to get treatment and they're told they can't get that treatment, or worse, what happens is after substance use treatment providers have problems with organizations, for example, like Health Net, they just stop accepting people with Health Net insurance. So you're paying $650, but you can't find anybody who's going to accept you because we know what's going to happen. I'm going to provide the treatment and then I'm not going to get paid. That's not in the best interest.
Why would I want to take your insurance?
Right, exactly. And that's what happens. Where does that patient go? They go to their emergency room and get charged 5 times as much, and the insurance company still pays that. Because now it's an emergency situation as opposed to paying the treatment provider a reasonable rate to provide treatment.
Utterly random.
Yes.
And with no preventative medicinal forethought into this.
That is correct.
I want to talk a little bit more about judicially where your work is right now and what's going on.
From a judicial perspective, what ATAC does is we monitor. So there is a mass action or mass litigation in California against Health Net because they stopped paying people in November of 2015 and didn't start paying people again until probably May of 2016, largely because of the efforts of the Addiction Treatment Advocacy Coalition. Now, did they pay at rates that we thought were reasonable? No, but at least they started paying something. There are people who are owed $1 million. There are people owed $500,000. How many businesses can go without $500,000 in bills being paid and survive? It's a horrible practice, and that's why we are trying to get the Department of Insurance to do something. They've been investigating for 1 year. I will say that they're doing the best that they can. And while people are going out of business because they are financially in crisis, they think that we've moved really fast. A year investigation If I were fraudulently doing something against an insurance company, they'd have that done in a couple of months.
Absolutely. And if I'm a treatment provider and my facility hasn't been paid in 10 months, I'm going out of business before you even get started. So I was talking yesterday to the father, a young man who has been through multiple treatment centers. He paid about $700 a month for a Health Net PPO. He was told it was the very best substance abuse coverage that he could buy. They not only delayed or denied payment to the provider, and they were obligated to pay, the policy said they paid 75%. He was reading to me bills he had for like $8,800, they paid $600. Now there was $9,000, they paid around $700 or $800.
Yes.
And it was just maddening. This guy was going crazy because he continued to pay these premiums. And
because most policies say they're going to pay 75% of billed, or some of them say usual, customary, and reasonable. Now, what does that mean? That means that the insurance company has a scheme or strategy, depending upon your perspective, that they determine what usual, customary, and reasonable is. It used to be by zip code. 90210, it is, okay, here's what the treatment facilities in 90210 are charging. Well, they decided to make it geographic, so now it's 902XX. So you go from Malibu to Compton. Okay, so that may help the treatment facilities in Compton, but it is not doing a very good job for the treatment facilities in Malibu, because obviously the cost structure of the treatment facilities are fundamentally different. And so these large geographic zip codes allow them to say, look at all these treatment facilities in Compton, and they're only $200 a day, and these treatment facilities in Malibu are $2,000 a day, we're gonna pay $600. Okay, Compton's dancing a jig.
yeah.
Malibu's not so happy.
So in your advocacy work, in your fight in the courts, in your fight administratively, how would you define a win for your organization?
When treatment providers are treated exactly the same. When you talk about mental health parity, the reason that there's a mental health parity law is because there's stigma and discrimination against people with mental health issues. I don't even like the term behavioral health issues, because behavioral health issues sounds like I'm in control of that. I'm not in control of that situation. Why don't you call my diabetes behavioral health? It's my diet and I don't move enough, right? And when I control my diet and I move enough, I don't have to take pills. But no one says anything about that for type 2 diabetes. No one says, oh my gosh, stop eating cornbread. Why is diabetes treated differently than mental health? Or why is cholesterol treated differently? We all know you can control your cholesterol through your diet, but no one does, so everyone goes on pills. Part of it's hereditary. I'm not gonna say part of your cholesterol is not hereditary, but it can be controlled. There's no difference between that and being addicted to a substance.
There's still some archaic thoughts and perceptions about the disease of alcoholism and addiction.
Yes.
So a lot of work is being done on the front lines in terms of advocacy about changing public perception. There's an organization, for instance, called Facing Addiction. They are working on a national level to destigmatize.
I'm quite familiar with them.
Right. They're working to destigmatize this problem by getting more and more people to come out and talk about their addiction.
Yes.
Taking the shame out of it. It's like you said, strength in numbers. The more people that speak out and say, yes, I'm an alcoholic in recovery. Yes, I suffer from an addiction. I'm in recovery. This is what happened to me. That's going to resonate loud and clear. So it would seem like the two coalitions are already kind of working together.
Oh, we work with Facing Addiction. Facing Addiction has about 550 members across the United States that represent all different types of people who are in the addiction. I met with them when they first started about a year ago, and they're more focused on the federal. We are focused on California, but we plan to go national. And I was out meeting with the White House drug control policy. And then while I was there, they asked to meet with me. And so that was the beginning of our relationship with Facing Addiction.